Hi, my name is Paula Blackstein-Hirsch, and this webinar is about quality improvement plans, aligning the content to the guidelines that are developed by Health Quality Ontario. And incidentally, you can obtain those guidelines from the HQO website. So let's take a look at the components of a quality improvement plan. As you likely know, quality improvement plans are required under the Excellent Care for All Act, and they follow a template and guidelines that, as I indicated, are available through Health Quality Ontario. Quality improvement plans have not yet been mandated for the community support service sector, but there are hints that they may be mandated at some point in the future. The Quality Improvement Plan includes two key components. One is the short form, which is a narrative intended to be no longer than 2 to 3 pages, and we'll go through the various subcomponents of that. And the second is a long form, which in fact follows a spreadsheet format, but is now actually entered into a portal that is on the website of Health Quality Ontario. The long form can actually be conceptualized as having two sections. On the left side, including quality dimensions, outcome measures, baseline data, and targets. So it's very outcome focused. And the right side includes the change ideas, process measures, and targets, which is more action plan oriented. We're going to walk through both forms and discuss the content that's expected in each form, including a discussion about the difference between various types of indicators. So this is what the short form looks like, and it lists the quality, the components that are included within the short form. So the first part is the overview, and we have another webinar that is focused on quality aims and priorities, which are not included in the guidelines, but which are a critical foundation for a quality improvement plan. And these can be included in the overview section of the narrative. The other piece that's included in this overview is alignment with other jurisdictional and organizational plans, and these are things like a strategic plan, an organization's operating plan, your MSAW, accreditation, any sort of report that's developed or planning exercise internally or required to be reported externally. The second area is integration and continuity of care, and the guidelines suggest that this should include how you're working with system partners, either within or across sectors. And the intent is to improve integration and continuity of care through your quality plan and to demonstrate how you're going to do that in this short form. The third area is challenges, risks, mitigation strategies inherent in achieving the objectives in the quality plan. Next is how you will leverage your existing information management system to support the indicators in the quality plan. And then in the next bullet, how you will engage clients, staff, and broader leadership in the action plan that is the basis of your quality plan. And then finally, in terms of accountability, how will leadership be held accountable for achieving targets in the plan? And that actually is what's specified in the guidelines, but I would add to that also, beyond leadership, what are the mechanisms that you will use throughout your organization, right down to the front line, for holding all staff accountable for achieving the targets in the plan? This is the first part of the long form. It's the left side that is more accountability or more outcomes, I should say, more outcomes focused. The far left includes a column that's focused on the dimensions of quality, and the 5 dimensions that are part of the Excellent Care for All Act are safe, accessible, person-centered, integrated, and effective. So generally there are indicators that cross those 5 dimensions. The guidelines include all of those dimensions, but in fact when quality plans have been rolled out to certain sectors, Health Quality Ontario hasn't always included all 5 dimensions, but organizations are free to include all 5 if they wish. Under the indicator column, the guidelines indicate that there are generally priority indicators defined by Health Quality Ontario that are already embedded in the portal. If an organization decides that one of those priority indicators is not relevant to their organization based on their own performance, there is not a requirement to actually include that in your own organizational quality plan. But because something must be completed on each row in the portal, on the far right is a column titled Comments, and you would need to indicate why you're not including that indicator in your quality plan, just so that something is inserted in that row. You can also add whatever indicators you'd like. So you may choose to report on some of the common or priority indicators that once Health Quality Ontario has defined these would be included. And at this point in time, using this template, but developing your own organizational quality plan, you can include whatever indicators you like, hopefully balanced across those 5 dimensions. What's key is that we include outcome indicators in this indicator column as compared with process indicators, and we'll look at the distinction between those in just a minute. So, what is an outcome indicator? It's an indicator that reflects the voice of the client. It's what clients care about, related to either the safety of service, the effectiveness of your service delivery, their ability to access your services, the extent to which your services are client-centered, and the extent to which they're well integrated within and across organizations. So that's the definition of an outcome indicator. Let's take a look and assess the content in each of these 2 columns in relation to the expected content in the Health Quality Ontario guidelines. So take a look at what's there under objective and indicator, and then look at the response options and decide for yourself whether these are very aligned to the ECFA guidelines, somewhat aligned, or not very aligned. If you selected very aligned, you were correct. Let's take a look at why. If we look under the objective column, the intent there is that there be a statement that is relevant to the indicator in the next column and that provides some direction, either increase or improve, decrease or reduce. So it's a directional statement. And indeed, this objective does include that direction. It's improved client experience with admission to our facility. If you compare this with what's in the indicator column, you'll note that it's not quite as specific or as detailed, and it doesn't really need to be. In the right column under indicator, we've got a measure that is articulated as the percentage of clients who have an excellent experience with admission and orientation to our facility. That is an outcome indicator. Really anything that shares client perspective on service delivery is considered an outcome. This is something that a client would care about. And just a note that with satisfaction data, it's important to include in the indicator the category on the Likert scale within a survey. So in this case, clients who would have ticked off excellent on a range of options that probably went from not very good, perhaps, to excellent. Let's try another one. Take a look at what's in these two columns and think about the extent to which you believe both the objective and the indicator are aligned or not to what's expected by Health Quality Ontario. So if you chose the second option, you were correct. Let's take a look at why. The objective, increase client and family input into goals of care based on changing client needs, is okay as an objective. It has a direction in it, and involvement in decision making or establishing goals is indeed something that clients care about. The indicator, though, percentage of clients who have reviewed, renewed care plans, is leaning more towards a process measure. It would have been even better and then would have been very aligned to ECFA guidelines if it were articulated as the percentage of clients involved in setting, who believed they were involved in setting goals of care, because then it's the client perspective on their involvement in decision making or their involvement in setting goals. So going back and taking a look at some of the next columns, moving towards the right on the long form, we're still on the outcome side of the long form. The next two columns are unit/population. So what's intended to go in there? Generally in quality improvement, we start testing ideas for change on a small scale, or what some may articulate as a pilot. And so the indication there is intended to be for whatever unit or whatever subgroup of your entire population you're starting to test this with. So let's, as an example, say that an organization provided multiple services, and this test of change and this indicator then is actually only reflecting an adult day program and doesn't include their day service, their adult, it focuses on their adult day program. It might not include their home service. It may not include their transportation service, their Meals on Wheels, etc. So it's confined to one of several services. Similarly, it might be that the organization services a range of clients, and that this particular indicator and the change idea is focused on individuals identified as complex or high risk for the organization. So you can define it however you like, and the intent is that you specify that subpopulation here. The next column, source and period. The source is just the data source for the indicator. The time period is either, if it's not a whole year, because this is an annual plan intended to go from April 1st to March 31st. Also, for some of the priority indicators, when specified, Health Quality Ontario might have a different reporting period, and then they would actually specify that in the guidelines. So let's take a look next at the next three columns: current performance, target, and target justification. And I think I'm going to cover the last column just while we're at it, looking at this form. So the current performance is basically your current year performance on that indicator. That forms your baseline for the next year. We're going to actually talk in detail about the target and target justification on the next couple of slides, but before we go there, just taking a look at the final column, maintain or improve. So you can include in your quality plan either an intent to improve something, in which case your target should be better than your current performance, or you can maintain or sustain, because we know that sustainability is challenging and that organizations need to put effort into sustaining performance. And so if you actually put maintain there, you would expect that your target and your current performance would actually be the same for between this year and the coming year. So let's take a look at how we set targets. They are expected to be aspirational. So what does that mean? High enough to inspire and motivate, but not so much of a stretch that it's not at all possible to achieve it within a year, or that it totally demoralizes your staff because there's no way that they can possibly achieve it. If the indicator is linked to one of your organizational quality priorities and the aim for that priority includes a 3-year goal, this annual target should take you a third of the way towards achieving that 3-year goal. Target justification. There are a whole variety of ways in which you can justify the target that you've set. Oftentimes, it's a benchmark that would be established through comparison within the sector. So, for example, that you want to be within the top 10th percentile, or you want to be within the top 25th percentile, or that you want to match the performance of a particular organization that you know of in the sector. It could be theoretical best. So, for example, for critical incidents, it could be 0, which is theoretical best for a critical incident. Or it could be moving toward theoretical best. Or it could even be this target is a stretch based on our own organization's experience with setting targets. And there are a number of ways in the guidelines that are reflected as well that you can take a look at for those target justifications. So we're building, we're going to take a look at 4 columns together this time. So let's take a look at the indicator, the current performance, the target, and the target justification. And I'll give you just a slight bit longer to take a look at these 4 columns and then reflect on these response options. Are these very aligned, somewhat aligned, or not very aligned to what's expected in using the ECFA guidelines? Okay, if you chose the third option, not very aligned to the ECFA guidelines, you were correct. Let's take a look at why. The indicator itself, percentage of clients who report a fall after receiving the fall screener intervention, is okay. It's an outcome indicator. Clients care about falls. They don't want to experience a fall. And it, excuse the pun, it falls within the safe dimension of quality. But if we look at the next column, current performance, there are a whole range of baseline information there, but they're really not linked to falls per se. There's nothing there about the percentage of clients with falls. These are actually results on what are probably process measures linked to various change ideas. So there was likely a change idea about certain professionals doing some kind of an assessment. There was likely a change idea about looking at, could be the home environment and looking at risk for falls. So a variety of change ideas, and these look like baseline information related to those. Remember, this is the outcome part of the QUIP. It's on the left side. These are process measure related, which is on the right side. The targets are potentially okay targets, with the exception of the first one, where you would expect that they were probably maintaining this. We don't generally want to maintain for a process measure, only for an outcome measure. So if this was on the outcome side, it would be okay to maintain, but on a process side, you'd want to see it increase. And then if we look at the target justification, falls analysis for 2014-15 provides baseline data. This doesn't really tell us anything about anything. It just says they did an analysis to get the baseline data. Let's try one more. Review these 4 columns and determine how well they align to the ECFA guidelines. So if you chose very aligned, you were correct. Let's take a look at why. Under indicator, the number of client or family complaints about service delivery. Complaints are an outcome, and they are relevant to or would fall within the client-centered dimension of quality. The current performance is what it is, but it is a count, and it relates to the number on the indicator. The target, so going from 25 to 10, that is indeed likely a stretch target for the organization, so that's good. And down is good here, obviously. And then looking at target justification, moving toward theoretical best. So that means moving towards 0 complaints. So that's good, it's very aligned. So we're going to move now to the right side of the long form. And this incidentally wouldn't be divided into 2 parts in the Health Quality Ontario template, or if there's a version that you can download of an Excel spreadsheet from the website, it would all be together. Remember that to the left of this are outcome indicators. And then on this right side, we're looking at the action plan. We're going to look specifically in a minute at the columns that have the frames around them, but before we move to that, I just want to say a word about the second column, which is methods. This is intended to be, as is articulated in HQO's guidelines, methods that will be used to track progress on planned improvement initiatives. For example, how the data on change ideas will be collected, analyzed, and reviewed. So it doesn't need to be filled in for every change idea, but that is the intent of the column if you need it. The other thing I'd like to point out before we move on is that for every outcome on the left side of the quality improvement plan, there should be at least 2 or 3 change ideas linked to each outcome indicator. It generally takes at least a few ideas for change in order to have an impact on an outcome indicator. So let's take a look at change ideas and process measures. Change ideas are basically the ideas for change that you hypothesize will help the organization to impact the outcome measures that are on the left side of the template. And when you look at these, they should be, or when someone else looks at them, they should be specific enough that someone can pick up the plan and actually envision what the frontline staff are going to be doing to test and implement the idea. So basically it should be in enough detail, which doesn't take more than a phrase or a sentence, that you can actually picture what the specific change is. Process measures then are always linked to change ideas, and they determine the extent to which the change idea is in fact being implemented. We talked a couple minutes ago about targets for outcome indicators, and there are a whole variety of places that you can get those, from benchmarking to your own experience, etc. Targets for process measures, on the other hand, always need to be, over time, 90 to 100%. Because they reflect the extent to which a change idea is being implemented, we need to know that it's actually been fully operationalized or fully implemented in order to impact outcome measures. So let's take a look at these 3 columns together. I'm going to give you a little bit longer just to take a look at these 3 columns and think about the extent to which you think these align to the ECFA guidelines. Okay, if you chose the first option, then you were correct. Let's take a look at why. So the first change idea is re-educating frontline staff on changing the conversation, and that's, I think, intended to be a specific program that people in the organization would understand what that's about. It's pretty specific, and there are actually two process measures here that reflect two levels of assessing the uptake or implementation. So the first one, and these are often articulated as percentages. So the percentage of staff who were actually trained on changing the conversation. That actually is kind of step one in terms of thinking about uptake, because if all staff need to do this, then we want to ensure that over time 100% of the staff are actually educated on how to do that. But holding the education and having people come only really goes part way there. The real intent of the change idea is that staff can actually gain the knowledge through the education that they can change the conversation. So this second process measure goes this extra mile by articulating the percentage of staff who demonstrate competency on changing the conversation. And you'll note that both of these targets are 90%, so they're within that range of 90 to 100%. The second row here is kind of interesting. It's about creating a client council. And so this isn't something that frontline staff are trying to do to impact an outcome, but it's sort of an organizational thing, and it's okay to include things like this as long as they don't form a majority of the change ideas. And so the process measure here is that they want to ensure that the council reflects the attributes of the client population. So they want it to be somewhat representative of the client population, and they want to ensure that it's established by the third quarter of the year. That's their target. So it's kind of like a strategic direction, but it's related to the quality agenda, so that's okay. And then the third one is teams testing and implementing always events, responding to client comments by service. And always events are actually a term that I believe was coined by NRC Picker that does standardized client satisfaction surveying. And then the process measure is the percentage of teams that have implemented an always event. So it directly measures the extent to which that change idea has actually been implemented, and the target is where we said it should be. One more example. I'll give you a few seconds to look at these and indicate whether you think these are very, somewhat, or not very aligned. So if you chose the third option, not very aligned, you were correct. Let's take a look at why. The first change idea, effective person-centered planning. If I picked up this quality plan, I really wouldn't know what frontline staff were doing to make change. This doesn't really tell me anything. It's very vague. The process measure, biannual reports and bi-monthly interviews, talks about the method for data collection. That's not a process measure. And the target of 50% is not between 90 and 100%. Now, I will point out at this time that it might be that if a change idea takes a long time to implement, more than a year, then you can actually put something less than 90 to 100%, but in the following year you would expect it to be up there towards 90 to 100%. The second row here, safe service delivery across the organization. Again, this isn't a change idea, it's a statement of aspiration. And safety compliance checklist is actually a part of a change idea. So it would be better if this was on the left side under change idea, and then there was a process measure that looked at the extent to which that was fully implemented. And there's no target established for this row. So that's the end of the content for this webinar. Let's just summarize what we've covered. The Quality Improvement Plan template, which is developed by Health Quality Ontario, is comprised of both a short form, which is a 2 to 3 page narrative, and a long form, which includes indicators and an action plan, and that is currently housed in a portal on HQO's website, and I do believe it's possible to download an Excel PDF or non-PDF version of it from their website. The short form, as I indicated, should be no longer than 2 to 3 pages, and it should include the organization's quality priorities, which form the foundation of a plan over time. And it's longer than the one-year horizon of a quality plan. Typically, those priorities cover a 3-year time horizon. The long form is outcomes focused on the left side and action plan focused on the right side. As I said, it's assumed to be a 1-year time horizon going from April 1st to March 31st. And the template, as you may have noted as we went through it, follows from left to right a logic model type of format that's similar to a driver diagram if you're familiar with that quality improvement tool. So that's the end of the webinar, and I wish you all the best as you experiment with completing your first quality improvement plan or your subsequent and even better versions of your quality improvement plans.